Hello and welcome to JCO Precision Oncology Conversations, where we bring you engaging conversations with authors of clinically relevant and highly significant JCO-PO articles. I'm your host, Dr. Naqash, podcast editor for JCO Precision Oncology and assistant professor at the OU Stephenson Cancer Center. Today, I'm very excited to be joined by Dr. Hatim Husain, professor of medicine at the University of California, San Diego, and author of the JCO Precision Oncology article, Adagrasib treatment after Sotorasib-Related Hepatotoxicity in patients with KRAS G12C mutated non-small cell lung cancer, a case series and literature review. This was one of the top downloaded articles of 2024. And the other interesting thing is we generally don't do podcasts for case reports or case series. So this is one of the very few that we have selected for the podcast. And at the time of the recording, our guest disclosures will be linked in the transcript. Dr. Hussain, welcome to our podcast, and thank you for joining us today.
Thank you, Dr. Naqash. Such a pleasure to be here and to speak with you all.
And for the sake of this podcast, we'll refer to each other using our first names. So again, as I mentioned earlier, that this is one of the very few case reports that we have selected for podcasts in JCO-PO. And the intention was very deliberate because it caters to something that is emerging, where we are trying to treat more KRAS mutant patients with different KRAS inhibitors. And you tried to address one very unique aspect of it in this article, which pertains to toxicity, especially hepatotoxicity. So for the sake of our listeners who tend to be community oncologists, trainees, academic faculty, can you tell us what are KRAS inhibitors? What is KRAS G12C? And how do some of these approved KRAS inhibitors try to inhibit KRAS G12C?
Sure. For a long time, actually, we've not had a selective way to inhibit mutant KRAS. And over the last several years, actually, now we've seen some dramatic advances here, particularly with the FDA approval of some of the selective inhibitors against the G12C variant. So KRAS G12C is an isoform of KRAS that is most common in lung cancer, and in fact actually is a transversion mutation in the KRAS gene that is a product of the carcinogen of tobacco. And in fact, the incidence of KRAS G12C in lung cancer is quite astounding, where as many KRAS G12C patients there are, there can be as, more than EGFR patients in certain populations and cohorts. The medicines Sotorasib and Adagrasib were rationally designed to be selective KRAS G12C inhibitors. And the way that they do this is that they lock the KRAS protein in the off state. KRAS is a protein that oscillates between an on and an off state. And by virtue of locking the protein in an off state, that has shown inhibition of downstream signaling and mitigation of tumor growth and, in fact, tumor cell death.
I absolutely love the way how you describe the on and off state, the oscillation, where the on is bound to the GTP and the off is bound to the GDP. And the two KRAS inhibitors that's currently approved, as you mentioned, are RAS off inhibitors, and they're emerging KRAS inhibitors that are RAS on. So now, as we have known from previous data related to immunotherapy and EGFR TKIs, such as osimertinib, where toxicity tends to be a compounded effect when you have osimertinib given within a certain timeline of previous checkpoint therapy. We've seen that in the clinic. As the data for these KRAS inhibitors is emerging, you talk about some very interesting aspects and data about what has been published so far with regards to prior use of immunotherapy or chemoimmunotherapy and the subsequent use of KRAS inhibitors. Could you elaborate upon that?
Sure. So for this population of patients, the first line approved strategy is a strategy that in most cases will incorporate immune therapy and chemotherapy. Immune therapy can have some important responses for patients with KRAS G12C. This may be due to the fact that KRAS G12C patients may have a higher incidence of prior smoking, perhaps higher tumor mutation burdens in some patients, and perhaps immunogenicity is defined in that context. So the standard of care in the first line currently includes immune therapy or immune therapy and chemotherapy. Where the current FDA approvals for selective G12C inhibitors are after the first line of therapy. There are a number of trials, though, exploring these medicines in the first line to see if they may be incorporated into a future treatment paradigm.
Thank you for that explanation. Now, going to what you published in this manuscript, can you help us understand the context of why you looked at this, even though the data just comprises of a case series of handful of patients, but the observations are very interesting. And these are real world scenarios where we often tend to be in situations where an individual has had toxicity on a certain drug and may have some response to that drug, but at the same time, the toxicity is challenging. And then you try to debate whether another drug in the same class might be beneficial without those toxicities. So you try to address that to some extent using this data set. So can you elaborate upon the question, the methodology, what you tried to look at, and important observations that you have?
Yes, our paper was actually inspired by one of my patients. My patient was a patient who had received chemotherapy and immune therapy. And actually in the past, even, additional lines of immune therapies, and was really coming to the edge of where standard treatments would exist. It was right at the same time that these selective inhibitors had been approved and the patient had received Sotorasib. And what was remarkable was when given Sotorasib, patient had a very high peak and spike in the transaminases. And we would do different trials of strategies around dose, around interruptions. And it was becoming quite difficult actually for the patient to proceed with additional therapy. It was around similar times actually, and I do want to make a note that the patient was progressing, driven in large fact by the fact that we've had to interrupt the medicine. So we feel and believe that the patient had inadequate dosing because of the level of toxicity that the patient was having with transaminase increase. So it was around the same time that Adagrasib was first commercially available that we were at that point. And we did a trial of Adagrasib post Sotorasib, largely driven by necessity without having additional options to provide this patient in our environment. What was remarkable was when the patient received the Adagrasib, there were no spikes in transaminases, similar to what we had seen before. And that really led us thinking is this adverse event of transaminase increase or hepatotoxicity, is this a class effect with KRAS G12C inhibitors? Or is it more nuanced than that? Are there different perhaps mechanisms by which the medicines may work that may more or less differentially contribute to this adverse event? And so that inspired us to kind of do a larger analysis, kind of really reach out to a larger network of physicians to gather insights and to gather responses in patients who had had a serial approach of Sotorasib and then Adagrasib. What we found in this process was, in fact, actually, there were many more cases of patients who resembled my patient, where the sequence of Sotorasib going to Adagrasib may have demonstrated differential contribution of hepatotoxicity in that context. And that really motivated us to put the publication together, to do diligence, and in the publication, spend a lot of time to kind of outline each patient case in detail around metrics surrounding time from last immune therapy, the number of days on Sotorasib, the best response to Sotorasib, the interval between Sotorasib and Adagrasib, the duration of Adagrasib, and then the grade of hepatotoxicity seen in each of the contexts, and particularly kind of the Adagrasib and patient disease status as well. We were quite inspired by the effort to try to, if we do not have randomized data in comparison of one medicine to another, which we do not at this juncture, we do not have a randomized analysis to really diligently and rigorously compare the rates of AEs across each medicine. And even in sequence, we do not have that with immune therapy. But what we felt was trying to get more analysis of this sequential approach of if patients had received a medicine, had to be taken off because of toxicity, and then actually tried on a new medicine, what were those rates? We felt like that was at least some information to try to get at this question.
And you bring forward a very important point, which is a lot of times in the real world setting, we don't have cross-trial comparisons that can be fully applicable, or we don't have trials that compare two drugs of the same class with respect to the AE profile or efficacy, and observations like the one that you described that led to this study are extremely critical in trying to help answer these questions. From a data standpoint, and you allude to it to some extent in your manuscript, the trials that are trying to address combination of KRAS G12C with immunotherapy, especially Sotorasib or Adagrasib. Can you elaborate on that data, what has been published so far, and summarize it for our listeners?
So there is data from clinical trials looking at patients actually who have received concomitant immune therapy and Sotorasib. What was seen in this in a real world analysis was that some patients actually who had received Sotorasib within a close proximity of immune therapy, as well as, a larger study actually, which showed in combination, there were higher rates of hepatotoxicity in that context. In fact, there were rates of grade 3 hepatotoxicity. And I think built upon that data, there's a recognition in the field that we have to be very diligent in terms of even the clinical trial designs in how to understand the pairing between immune therapy and selective G12C inhibitors. There are many trials that are ongoing. One of the studies that is ongoing is known as the Crystal 7 study, which is evaluating Adagrasib in combination with pembrolizumab in the first line. And we await more information on that strategy as well. In the context of Sotorasib, because of some of the trials actually that have showed higher rates of hepatotoxicity, there are some additional trials now looking at Sotorasib in combination with chemotherapy, and those also have some information that have been reported as well.
From a drug development standpoint, as you mentioned, there's always a tendency to combine something with something else. And in my practice, and I'm sure in your practice too, when we do early phase trials, many trials are still focused on choosing the maximum tolerated dose, which may be something that we need to gradually move away from as we try to implement these combinations of multiple antibodies plus some of these target agents, where maybe the biological optimal dose rather than the maximum tolerated dose is a better way to look at the drugs, the pharmacokinetic profile, and then see what is likely the safest combination with the most appropriate target engagement. Do you have any thoughts on that or insights on that from a drug development perspective?
It's a wonderful question, and I think very insightful question and understanding of where we are in the space right now. And I agree with you that historically, cancer drug development was really hinged upon medicines that perhaps required higher doses to see a benefit or to inch out kind of marginal increases upon where we were at. Now, in combination with medicines that have non-overlapping mechanisms of action, the concept is, can there actually be more synergy across an approach using combinatorial strategies rather than just additive effects? And I think that in some cases, this is being studied with immune therapy. In some cases, actually, even in the context of other novel mechanisms for cancer therapy. I think that in my practice, I will really try to see how a patient at an approved dose will respond, but definitely I'm open to the concept that there may be a dose that doesn't have to be the maximally tolerated dose, but rather the dose that responses can be seen, and perhaps actually at a lower dose than what drives many toxicities.
I often describe this to my patients as individual patient dose optimization outside of a clinical trial, where I'm sure you've probably done this, where older adults, maybe a lower dose of osimertinib is tolerated better, or a lower dose of sotorasib or adagrasib for that matter, tolerated better with perhaps a similar level of efficacy, since we don't have comparisons between doses and efficacy so far. So I think in the bigger picture, as we discussed, in a nutshell, what I would really like the listeners to understand is, as we try to move towards this field of precision medicine, targeting more and more of the undruggable genes, there's bound to be a certain level of toxicity patterns that we'll start observing. So I think these real world scenarios, which may not be addressed using clinical trials, because it is in the real world setting where you cycle one treatment after another, which may or may not be allowed in most trials. And the real world setting can inform, in certain cases, subsequent trial designs. So I think the most important message, at least that I took from your manuscript, was that these real world observations can make a huge difference and inform practice, even though the data sets may be small. Of course, we want to validate some of these findings in a bigger, broader setting, but proof of concept is there. And I think next time I see an individual in my clinic where I see better toxicity, I'll definitely try to talk to them about subsequent treatment with another KRAS inhibitor, maybe adagrasib or something else, if and when appropriate. Do you have any closing thoughts on some of these things that we discussed?
I just want to leave the audience actually with this concept that sometimes we group targeted therapy side effects as being class effects unanimously. And I do think actually that each inhibitor may have different off-target effects on where medicine may act. We don't truly understand the mechanism of hepatotoxicity in the context of selective KRAS G12C inhibitors. One of the hypotheses may be due to off-target cysteine reactivity in the numerous off-target binding sites that certain medicines may have over others, and just even qualitatively which off-target binding sites there may be and how that may lead to either immunogenic responses in other organs or such. So I do think that we do need more research to understand the mechanism. But I think where we are at right now in this space is not assuming that all medicines are going to have the exact same toxicity. I think especially when patients may not have other options, this is something to consider as well.
Thank you so much. Now, outside of the scientific insights, Hatim, I know you a little bit from before, and knowing the kind of work that you've done in precision medicine, I'm really interested to know about where you started, how things have been, and what kind of advice you have for junior faculty fellows who are interested in this field of precision medicine that is becoming more and more exciting as we progress in the oncology space.
Thank you, Ricky. I will say, actually, as a medical student, I was actually very interested in oncology, partly because it was then and still remains one disease or a constellation of diseases that just has such a high psychological burden on patients. And through the experiences I've had, I really can understand and relate with that concept. I did my medical school at Northwestern, residency at the University of Southern California, and then my oncology fellowship at Johns Hopkins University. And now I've been on faculty at University of California, San Diego for about 12 years now. It's been a great experience, paralleled with the fact that during these last 12 years, I've really seen how the developments in precision oncology, both targeted therapy as well as immune therapy, have really blossomed and unfolded. A large area of my research in my career has kind of focused on cancer genome and integration of novel technologies to really see how they may have clinical application. When I was in my fellowship and as a young faculty, the liquid biopsy was actually coming into development. And this was hinged upon information that had come forward in the prenatal space, where some patients actually who were undergoing prenatal testing during pregnancy were found to have complex karyotypes and genomic alterations, and then retrospectively found to have cancer. And doing my fellowship at Johns Hopkins, some of the pioneers in liquid biopsy were my mentors, and really kind of instilled in me that passion for really thinking through how cancer genomics can be integrated through time. And some of the research that I have been doing has been looking at clonal evolution of cancer, how cancer is changing over time, and how we can think through the right surveillance strategies to really understand how that change is occurring. The dynamics of ctDNA in retrospective cohorts have been studied and shown that, there can be associations between a progression-free survival and other clinical endpoints. The current paper that we are speaking about parallels that in a certain way where rather than, say, looking at clonal evolution and, say, the efficacy answer of Sotorasib first and then Adagrasib, and how frequently can Adagrasib salvage patients, this looks at it from a different angle around toxicity. And I think that is a key point because at my core, I really do enjoy the clinical aspect of complex decision-making on behalf of patients, weighing efficacy and toxicity that they may have as they try to get the best quality of life through this journey.
Thank you again, Hatim, for all those insights, both from the scientific perspective as well as personal perspective. We appreciate that you chose JCOPO as the destination for your work. And thank you for listening to JCO Precision Oncology Conversations. Don't forget to give us a rating or review and be sure to subscribe so you never miss an episode. You can find all ASCO shows at asco.org/podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.